So we've taken a look at blood flow through the heart and figuring out how it is passing through these one-way valves and beating out to the rest of the body. But let's now start diving into exactly how are these heartbeats happening. And to do that, we have to start with the electrical conduction system. So we're starting with the neurophysiology of what's happening within the heart in order to produce these contractions. So, taking a look at the electrical conduction system. So, the function is to be able to create and transmit an electrical impulse, right, to the muscles of the heart, the myocardium. So when we were talking, when we look at neurophysiology and we have an electrical impulse that can ultimately lead to a muscle contraction, the same thing is happening within our heart. A little bit differently, though, in that it's actually originating from the heart itself instead of originating from the brain. So it's actually found inside of the heart walls, and the different components of what we have in the electrical conduction system is we have the pacemaker that sets everything in motion, which is the sinoatrial node, also known as the SA node. We have these pink colored internodal pathways traveling through the atria. They come together at what's called the atrial ventricular node or atrial ventricular junction. Then it travels down through the bundle of His, which is outlined in the purple here, named after Dr. His. And then it goes through the bundle branches and ultimately into these fibers here called the Purkinje fibers. And the Purkinje fibers are actually spelled differently in like every medical textbook that you'll look at. Um, we can't seem to be able to actually agree on a spelling for it, but these are the fibers that are going to innervate the actual contractile cells of our ventricles to be able to produce that contraction to beat it to the lungs and to the rest of the body. So the way that it does this is through this electrical conduction system. And the way that we can actually visualize this happening within the heart is through what's called electrocardiography. So it's taking a look at the electrical system in the heart and it's graphing it out for us to be able to see it visually. We term this as an ECG for the electrocardiography, right? Or EKG, because of the German spelling of cardio is actually with a K. So those are the two different acronyms that we can use, ECG or EKG. I tend to say EKG a lot more just because of my upbringing and training that I've had. So I'd like to introduce you to Willem Einthoven. Einthoven is a Dutch physician who back in 1901 is the one who actually developed a system to be able to graph out electrical impulses onto a piece of paper. It was actually quite revolutionary for his time. And in 1924, he actually won the Nobel Prize for being able to read heart rhythms. You can see in these pictures located here, this is what the original EKG machines looked like. And now they are simplified to the point where you can carry them around in a small handheld device. So it's just kind of interesting to be able to see where technology has come and to realize that really this is fairly newer technology in the world, being is that it was only between 1901 and 1924 that this was really developed. So, what exactly is an EKG machine? Well, essentially, it's just giving us this graphical representation of what the electrical activity is within the heart. So, it takes an ohm reader, which is measuring electrical impulses. It's going to combine it with a printer, and you're going to add about $50,000 to it in order to come up with an EKG machine. This is one that is used in paramedicine, but they have many different kinds that you can be using. And in fact, you can run them off of computers now and handheld devices. So, what is it that we're actually looking at? So, whenever we have electrical impulses occurring within the heart, which is happening all the time, they produce different vectors. And vectors are essentially the amount of, it's just an amount of energy and a direction to it, right? When you have vectors that are going in the same direction, such as right here, where you've got a unit of energy and a direction here, and it's another unit of energy going the same direction, it basically will just multiply it out. It adds it together, right? They can also cancel each other out if they're going in opposite directions. So if we have the same amplitude of energy, the same amount of energy, but it's going in two different directions, it can cancel each other out. If you have energy and vectors going at an angle, they can either add or subtract energy and change directions when they meet. So we're basically going to take a look at all of the vectors that are occurring within the heart from the electrical impulses, and we're going to sum it all together to create what's called the electrical axis of the heart. So when we look at all these individual vectors that are all firing within the heart and you add them all together, overall, in general, we tend to have a vector that is moving from the upper right portion of the heart down to the lower portion of the left ventricle. And that's the sum of all of those vectors added up. What I want you to think of is that essentially looking at these vectors or looking at the lead or the axis of the heart and this graph that's going to come out, it's a picture of the heart, of what's happening electrically within the heart, right? So we can place different electrodes around the body, and they're going to read what's happening electrically within the heart. Now, I'm going to go back to this picture. So these leads that we can place different places are just cameras. They're cameras that are here, and they're taking a picture and recording whether the energy is coming toward the camera or whether it's going away from the camera. So like in here, we have the electrical impulse moving away from the camera compared to this camera. But at this camera's view, we actually have an impulse moving towards that camera. Now, when we look at the picture, it's going to look different based on which camera we're looking at. Ultimately, when it comes down to it, we typically look at the camera from this point of view because it is the one that most is in line with the vectors aligned within the heart. So this is called lead 2. We have different leads that we can look at, which are just the different electrodes, the different pictures of the heart. And the one we most often look at is lead 2, which is the name of this one down here because it is in line with the flow of the normal electrical activity within the heart when all added up. So what I want you to kind of visualize in your mind is that you are a cameraman and you are standing on a positive lead. Everything moves from negative to positive, okay? When we are standing on the positive lead and we're taking a picture, if the positive impulse is moving away from the electrode, so away from you, so you're standing as the cameraman, and we see this positive impulse moving away from me, it comes out with a picture of a downward wave. So it's something that'll be below the baseline. I'm going to show you a picture of this in just a moment, but I'm going to describe it with my words first. If you are standing on a positive lead and the positive impulse is moving toward you with your camera, it is going to be appearing printed out as something that is above the baseline. So it's an upward wave. And what the EKG or ECGs do is it's showing the positive deflection for energy that's coming toward it and negative deflection for energy moving away from it in a graphical representation. So we have our two leads. We've got a negative lead and a positive, or two electrodes, a negative and a positive. When you are standing on the positive, because the cameraman always stands on the positive, if you have the electrical impulse, this vector is moving toward you, right? So you're standing on the positive and it's an impulse that's moving toward you. Remember, that is going to show you an upward wave. So compared to the baseline, you will actually see a spike in it coming up. If you are standing on the positive lead and instead the vector is moving away from you, you're going to experience seeing that as a negative deflection from the baseline. So it's a downward wave. When you are standing on the positive, and instead of it moving away or towards you, it's actually just moving next to you, we can experience this two different ways. It can either be called what's biphasic, which it goes kind of up and down and then returns to baseline, or it can register just as a flat baseline, saying I'm not reading any electrical impulse because it's canceled itself out with it being completely perpendicular to itself. So sometimes it'll appear as if it goes both towards and away, and sometimes it just appears as if it's not there because it's not sure how to read it when it's passing by it, as opposed to coming slightly towards it or slightly away from it when it's completely perpendicular to it. So when we were talking about these different leads, so what we have is we can actually position these electrodes across the body. So one comes up to the right arm, one comes up to the left arm, and one comes down, and it's showing it in the middle, but often it's kind of over here in this direction on, and you can see its left leg. So this is right arm, and left leg, but it kind of creates this sort of a triangle. Usually it's just a little more tilted towards the left side. Now, if we were looking at the camera being placed over here where that left arm would be, we would be looking at the graphical representation of lead 1. If we were down here at the left leg and we were looking up, we would be looking at lead 3. But as I said, the majority of the sum of the vectors moves in this direction, right? It moves in this direction across the heart, which is most commonly seen through lead 2. So this is our lead 2 that we are looking at with our camera right here looking back towards lead 1. Now, when you're actually putting electrodes on them, a lot of times it'll be, we need a grounding station as well when it comes to electricity. So what we'll do is we'll have one on the right arm, one on the left arm, one on the left leg, and then also as the ground, we'll have it here on the right leg. Now, this is where we often put them because of artifact that can happen when you are moving the appendages at all. And so they try to put them on the core of the body. But actually, to get the best picture of the heart, we can actually put them on the extremities. We just have to make sure that the person was sitting or laying really still so that any movement of the arms or legs isn't what we're reading. And instead, it's actually the electricity of the heart. So let's talk about like what are we looking at and what is happening within the heart when we see this graphical representation. We're going to look at the basic beat. So this is what a normal sinus EKG rhythm looks like. So it's split up into different waves and segments and intervals that we all have. Ian Tovin is the one who developed it, and he wasn't sure exactly what he was looking for, and he wanted to name all of these different waves or changes from the baseline. And so he picked a middle of the alphabet letter to start with. That's why it starts with P. So it starts with P and then it goes all the way through to T. And there's actually a U wave that's involved too, but we're not going to address that right now. But it's interesting because it's randomly picked and just that he wanted something in the middle of the alphabet so that if he had to add something before it or something after it, he would still have enough letters to be able to do that. So let's define a couple of these different things. So a wave, when it comes to an EKG, is any deflection from the baseline that represents some kind of a cardiac event. So it means something has to be happening in the heart, and it's a deflection from the baseline. So it's either going up or it's going down. That's what a wave is. A segment is a portion of the representation of what's happening in the heart that's kind of just It's just a section of it. It's just a segment of it, and it's usually around the baseline level. So you can see that we have a segment down here, right here. We also have another segment that leads from here into the next beat that'll be coming. So those are some of our segments, and we also have a segment right here. So they're along on the baseline, typically on the baseline in a healthy individual, and they're just sections where there's like a pause in what's happening. An interval is measured as time, and it's when you are combining usually a segment and wave or waves. So it's kind of like an event that's happening between two different cardiac events. And then the baseline is just the line that is going in between one beat and the next. So the next one that would be coming, right? So that's just the baseline to let you know, like, this is where the heart is starting out when it's not doing any electrical activity within the heart. And then we've got waves and segments that combine into intervals in order to show us what's happening with our electricity within the heart. So taking a look at the P to R interval. So the P to R interval starts at the very beginning of the P wave. So the first wave we see right here is the P wave, and it goes until the beginning of what's called the QRS complex. So it includes both the P wave and the P to R segment. Now it looks really simple on this graph where you just have a little bump and then a line, but there are so many different things that are happening during this P to R interval. So we're going to take a look at it. This is when every single one of that electrical conduction system is firing. The whole entire thing is firing at this time. So it starts with the SA node. The SA node fires just previous to where the P wave begins. The atria contractile cells are also at this point firing through going down the internodal pathways, and then it actually contracts the heart muscle cells that we have within the atria, not just the electrical conduction system. Then it contracts in our electrical conduction system, going through the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. So this all travels super quick, so it can be a coordinated contraction of the heart. So all of these cells are firing, as well as the contractile cells of the atria. So looking at the graphical representation, it's all of these cells in the electrical conduction system, all the way down to the Purkinje fibers, as well as the contraction of the heart cells in the atria, the contractile cells to actually contract the atria. Next, we have the QRS complex. The QRS complex is going to look at our ventricular myocyte contractile cells contraction. So this is our myocardial ventricular depolarization, which essentially means it's the myocytes. So those are the heart muscle cells in the ventricles are the ones that are depolarizing. So contraction is happening in the ventricles at this particular time. The main component is that you have a Q wave, which is what starts off the QRS complex right here. Q wave, this is the R wave as a deflection, and then an S wave as it comes back down. So the R wave is the first positive deflection that you'll see after the P wave. So that's kind of how you can shape it. And that's the initiating of what we can see with the QRS if the Q isn't present, because we can't always see a Q wave. This is the contractile cells moving through the septum to be able to move into the ventricles. And sometimes is seen as a negative deflection. Then after the QRS, so after we have ventricular depolarization and contraction, right? Then we have this neutral period between when those ventricular cells fired and when they repolarize. And this is what's called the ST segment. So it's the segment from the end of the QRS complex to the beginning of the T wave, which is our repolarization. And it's usually found at the same height as what the baseline is. So here we've got our baseline here, our P wave to our P to R segment. Here's our QRS, our ST segment here, which is usually the same amplitude of what you saw on the isoelectric line or the baseline. And then begins our repolarization of our T wave. And then it resets back to that isoelectric line or the baseline. You can call it either way. When this is not at the same level as the baseline, there's something going on in the heart. So if it's elevated and it's actually above, so if it was up here before the T wave and then came back down for the isoelectric line, it would be representing that there is actual injury happening to the heart at that particular time. If instead it was below the baseline, it's called ST segment depression, in which it's showing that there is a lack of blood flow, which is bringing a lack of oxygen to the heart at that particular time. So you can actually tell a lot about what's happening in the heart by looking at where is this amplitude of this ST segment, which I think is fascinating that we discovered this back in 1924, right? So just looking at here. So we've got our P wave, our P to R segment right here, our QRS, and then this is our ST segment with our T wave right here. So what we'll notice is right here, we have the same amplitude as what we saw here on our baseline or our isoelectric line. So this is normal, healthy, right? No injury is happening. Here would be ST segment elevation. So this is where our isoelectric line should be. And you can see that dotted line that's traveling there because that's where it would be connected as far as if it was at the same as the baseline. However, this ST segment is actually elevated. It's called ST segment elevation, which means they are actually having an injury happening to the heart right now, which is what we call an infarct. And what you may remember that or know that as is a myocardial infarction, which is injury to the heart muscle, which in layman's terms is a heart attack. So a person who is having this ST segment elevation right here is currently in a heart attack. And you can tell that just by taking a look at the EKG and seeing what that graphical representation is looking like. In this case over here, the isoelectric line should be continuing right here, and that's where we would want our ST segment to be. But instead of it being at the line or elevated, it's actually depressed. So this is called ST segment depression because it's below where we would expect it to be. And this means ischemia is happening. And ischemia is a lack of oxygen because of a lack of blood flow. So because there is a lack of blood flow, we are not getting enough oxygen to the heart cells themselves, that it's causing a little disruption in the electrical conductivity of the heart. And it's coming through on here. It doesn't mean that there's actual damage being done to the cells. It just means it's having a temporary blockage in blood flow, leading to not enough oxygen getting around. An infarct is when there's actually tissue damage that's happening. And then lastly, we end with our T wave. And when you look at the T wave, it's our ventricular repolarization. So all the ventricles, all the cells in the heart itself and the ventricles were contracting right here, and they all have to repolarize, right? So it's the next deflection, whether it's positive or negative, after the ST segment. And it usually begins in the same direction as what the QRS complex was. That's what a normal T wave looks like. And it's also normally asymmetrical, meaning that it rises a little bit more slowly and then it moves faster as it's finishing off. If it's completely symmetrical, that usually means there's something wrong in the heart because it's going at a different speed of repolarization than what it normally does. So, just kind of pulling out a few more intervals that I want to talk to. We often reference the R to R interval, which is essentially from one R wave to the next R wave. And when we look at this, it's actually giving us a graphical representation of here ventricles contracted and here ventricles contracted again. So it's measuring essentially the whole cardiac cycle, going from ventricular contraction to ventricular contraction. It's like the whole series of events that you have. You can also do it from the P wave to the P wave, which is the P to P interval. It's just harder to visualize the P waves as it is compared to the R waves. So a lot of people just go R to R interval, saying that it's like from one heartbeat to the next heartbeat. So this is kind of just our overall giving you a picture of everything that is happening within the heart. Remember, we have the P to R interval, which is giving us all the conduction system is firing, as well as the contractile cells of the atria. Then we have ventricular depolarization of the myocytes for the ventricles are contracting here. Then we have a period of rest before those ventricular cells will repolarize. Now you might be asking, what exactly? We had depolarization here of the atria. What is going on with the repolarization of it? Well, actually, that repolarization is it's hidden within the QRS complex. So it does, the atria do repolarize. We just can't see it graphically because it's happening at the same time that the ventricles are contracting or depolarizing. So that's what you're gonna get it hidden on that respects. So it gives you a picture of what is going on when it comes to the electrical conduction system of the heart.